Guys, we have with us Dr. Anurag Agrawal. He is the professor of anesthesiology and pain medicine in one of the premier institute of India, Ram Manohar Lohia Institute. Uh, he is a pioneer. We can say that he is the pioneer in endoscopy in India, and we all started together. And since then, we have seen a very rapid growth in spine endoscopy in India, and he's been instrumental in developing this field in India. Uh, his area of interests are mainly the advanced intervention, like spine endoscopy, vertebral augmentation procedures, and he is one of the first one to introduce balloon compression for trigeminal neuralgia in India. Uh, he's a good friend and excellent teacher and a great practitioner. That is the most important part. So over to you, Anurag. So he's going to cover the instruments what we use for spine endoscopy, and uh, along with that, the radio frequency RF equipments and other equipments, the supporting equipments. He is going to cover everything in this lecture. Yeah. So Anurag, over to you.
Thank you, Pankaj Bhai, for a very great words and introduction. I don't know whether I deserve that or not. So, and I'm really happy and thankful to you for giving me this opportunity to discuss spine endoscopy, which is the common passion of us with our friends throughout the world. So, good evening to all. Sorry for the glitches. I am poor with computers and all that. So today we are going to talk about the percutaneous spine endoscopic instruments. I understand that most of you are venturing and you are trying to enter into the exciting field of percutaneous spine endoscopic interventions. And for that, it is our common belief that you need to understand your equipment very well because like all other equipments like the radio frequency pain management generator, like the vertebro and kyphoplasty equipment, like the balloon compression equipments, here the instruments are slightly more on the surgical side. On the or rest all other instruments are on the interventional side, they are more like needles, but here more than needles are required to do a successful intervention endoscopically. So this is me. I am working as Dr. Professor Range said that as a professor and pain spine physician at Dr. Ram Manohar Lohia Institute of Medical Sciences, Lucknow, Uttar Pradesh, India. And now to come to the main topic, why it is important to understand the equipment and the spine endoscopy if you are a pain physician or you want to be one. That percutaneous spine endoscopy is the pinnacle of all MIPSs. And MIPSs is a word that is a common umbrella word for all the interventions, which has been introduced during his tenure by Dr. Pankaj Surange as the Secretary for Indian Society for Study of
Sir,
Pain.
we can't hear you.
You can't? Oh, but you were earlier able to hear me?
We can hear. We can hear.
I
You can
can.
hear?
I can.
Yes, sir. We can. We are hearing, sir.
We
We
are
are
hearing
hearing.
you.
So who was complaining? Like, please check your speakers now. Hello, should I go ahead? Hello,
Yes, sir. Yes,
should
sir.
I
Yes,
go
Yes,
ahead?
sir.
sir.
Yes.
Yes,
From
sir.
my side, please go ahead.
Yeah, thank you. So, the MIPSI is the word which I was telling that is minimally invasive pain and spine intervention. And why it is still it is a pinnacle? Because here you can objectively prove that you have done something good for your patient. uh, that you can show the fragment which you have removed. You can get the post-operative CT scan or MRI to show that what you have done, like it happens with all most of the clinical branches like orthopedics and neurosurgery, etc. So, but this spine endoscopy requires some special equipments, and the whole thanks from everybody who's doing spine endoscopy across the world goes to original developers like Dr. Anthony Young in US and Dr. Thomas Hoagland, Dr. Rutan in Germany, and others like Dr. Contact Lim and Dr. Kim. So the first and foremost thing of the spine endoscopy equipment is this is a rigid endoscope. So it is very important to understand that it is not a flexible one. Many of us are known to epiduroscope, which is a flexible bronchoscope type of thing, which you go through the caudal epidural space into the posterior or anterior epidural space and remove the adhesions. But here it is a rigid endoscope. You cannot bend it. So whatever the free-form shape is there, it will remain the same. The second most important thing which makes this spine endoscope different from the other endoscopes like they use in the ENT surgeries and other laparoscopic surgeries, that this is all in one scope. Everything is in the single rod. So this is the reason it is also known as rod lens endoscope. It has been developed in the last decade of the last century, 20th century. The development was started somewhere in 1980s, 85, 88, and then it gradually increases and getting better. So different sizes are available here, as you can see here. Sorry. Uh, oh, yes, you can see that these are different sizes. And you can also see that there are different gauges also. This looks like thin but short. This is shorter than this one, but thicker. And this is longest and thin. The thickness of this one and this one are same, but the thickness here is more. The diameter is more. So they are for different purposes. Like this one is useful for the transfemoral route. This one is perhaps useful for the interlaminar route, and this is for the stenotic decompression. So, as you get better and more advanced with the endoscopy, you will require actually all three of them, not one of them. So, rod lens endoscope, as I was telling, it contains a working channel, it contains a light source, it contains a irrigation and suction channel, and it also contains the camera. Everything in a single rod. So this is the distal end of this endoscope where you can see that the largest part is the working channel, which is very, very important. I will tell you why. And then it is the camera, and these are the irrigation channels. So this working channel, the bigger the working channel, the bigger the hand equipments you can use and do the job more effectively and in more timely manner. So second thing, which is very important again, and we must salute to the developers who thought of it. This is not a 0 degree slope. This is a beveled or tapered slope. So which brings this camera ahead of this opening, this working channel. So that makes that you see the light not like this. You are seeing like this. So the vision you are looking at like this, not like this. So this is not 0 degree. This is rather 30 degree, 25 degree, 15 degree. Different scopes are, but usually it is 20 to 25 degree. So you are looking at this. So you are looking not only ahead, but above also. So this is a very important feature of this rod lens.
There is a conical dilator. So here you can see that this dilator is conical, is blunt tipped conical, and it goes over the K wire. And the specific purpose for making this dilator conical is not to cut any tissue, rather to dilate it. So that is the beauty, because we want to keep it as minimally invasive as possible. Then comes the working sleeves. Once you have placed your needle through that the K wire, over the K wire conical dilator, and you have reached the place where you want to reach, you use this working sleeve. So again, the working sleeve diameter is usually 8 mm for transfemoral route, and this is again the tapered one. As the rod lens is tapered one, this guide wire, this working sleeve is also tapered one. And this is very good for when you are using half and half technique of inside out transfemoral endoscopy. And other type of end, like for rhizotomy, that is the middle branch rhizotomy, 0 degree working sleeves are also available. Then comes the hand equipment. These equipment, till now, we were talking about the equipments which are required for the placement of sleeve, and through the sleeve goes the endoscope. Now we are going to talk about the hand equipments, which are actually doing the work to cut the tissue, to remove it, or to ablate it. So one of the most important equipment which you require is the annular punch or annular cutter or simple knife. Sometimes there are different names for the same thing actually. The purpose is to release the trapped nuclear material, which is released, which has come out through a small hole into the annulus and which is causing the herniation. You cut the annulus unless you cut that annulus, that nuclear material which has been extruded cannot be released. And till it cannot be released, it cannot be removed. So it can be curved or it can be straight. Length is usually dependent on the endoscope which you are using. But for the transfemoral route, it is usually 21 to 25 centimeters. And again, the diameter is also important. For the thin scope, you can use thin equipment. For the bigger scope, you can use bigger equipment. So the usual sizes are available in 2.5 to 4 millimeter of size. 4 millimeter of size can be used only in a scope which is bigger than 5.5 millimeter of internal diameter of the working channel. So it is always advisable to have a bigger working channel equipment if available. And they are coming from few companies, but which are slightly costly, but I would suggest that you go for them only. Then comes the nerve hook, which is a blunt and articulating tip equipment. When you press the handle of the equipment, the tip comes out and straight tip becomes like this bend, So you can use it to release break the adhesions, to sweep the floor of the spinal canal and to bring the fragment in front of you so that you can grasp it and remove it. So it is very important tissue again. And blunt tip is again very important because you do not want to injure either the dura or the nerve which is going through there. Then comes the endoscopic Carrison punches. Again, as you advance into the endoscopy, these endoscopic Carrison punch become one of the very, very important equipment because then you start doing some bone work also. You start doing some laminotomies, not laminectomies, laminotomies, partial removal of the lamina. That is required to do the little recess stenosis work or the central canal stenosis work. So there are different sizes are available and there are different angulation are available, which may be 45 degrees or 90 degrees. And this is one of the single most important equipment for the PSLD, that is the percutaneous stenotic lumbar decompression of the patient of lumbar canal stenosis are increasing worldwide. So you need to have very good quality Carrison punches of different sizes. Again, bigger the scope, bigger the punch you can use, and more work you can do. But again, on the flip side, bigger the punch, it becomes more risky. So you must know what the equipment you are using and how to use and where to use. So then there are few other equipments which are sometimes requires. So when you start doing it, you may or may not have them in the initial period if there are any financial reasons. Otherwise, they are sometimes very useful, which include the bone chisel, curate, which you can use to remove the osteophyte, or sometimes it is very useful for the old calcified disc. When disc is there, but you cannot grab it through the grasper because this is very much hardened disc. So you have to break it down using the chisel or the curate before you can remove it. Then there are sometimes your patient are having foraminal stenosis because of the degenerative disc height is reduced, SAP is going up and pinching the exiting root. And then on the X-ray, you find that there is a very less foraminal space available for the exiting root. So that you do the foraminotomy. You increases the size of foramen by reaming the undersurface of SAP, which makes the roof of foramen. Remember, your patient is lying prone. So, and this is the SAP. This is the, suppose this is the foramen. So this part is SAP. So you ream this ventral surface of the SAP to increase the size of foramen. And on the downside, this is the disc. So you remove some part of disc. Also, you remove the foramen. So there, these equipments are very useful. So few companies make them. Ours, which I am showing you, is the indigenous one. It is blunt tip and different size. The size starts from the 4 mm to 6 mm to 8 mm to 9 mm. So we use them over the guide wire under the CR and with the sequential manner to ream the under surface of SAP to increase the size of foramen. So it is very good equipment also. Then comes different sizes of grasper to remove the disc fragment, actual disc fragment, which you are aiming to do it. They are different sizes. Now flexible graspers are also available, which can have some directionability. Hello. So then comes the single most important equipment without which you cannot even think of doing endoscopy. That is the radiofrequency cautery. So this is it is important to understand that the endoscopic radiofrequency cautery are bipolar type. Second thing, the power of these cauteries is very important. That is 4.1 megahertz. So the normal, you will be surprised, you might be surprised that the normal radio frequency pain management generator, which we use, has got a very low hertz. But here it is 4.1 megahertz. And what is the use of this so much high megahertz power of this radio frequency? That the lateral spread of heat is only 0.6 millimeter with this much of power. Suppose it becomes a 2 megahertz or 1 megahertz, the lateral spread become 1 or more than 1 millimeter lateral heat transfer will be there. So that makes the nerves vulnerable when you do the radio frequency ablation or the hemostasis for this thing. So with the 4.1 megahertz, the lateral spread is only less than 1 millimeter. So you can work very close to the nerve or dura using this equipment. Second thing, it can coagulate as well as ablate the tissue. There are some unwanted tissues which you don't want to remove, rather you want to shrink them to clear the surgical field. And it is also useful to stop the bleeding. So this has got a flexi tip. When you press the handle, this tip goes like, not like this, rather like this. So you can also use it for the clearance of the tissue. And if you can see and appreciate, that is a blunt tip. So it is not going to harm any structure. Then comes the drills. Again, these are the advanced equipment, but you will require them if you want to do advanced endoscopy work. So they are in the different sizes available and different companies are making them. So they are conical, they are oval, they are circular, they are of carbide type, they are of diamond type, they are of conical type, and they are very, very important to do the bone work. Because remember, you are doing very fine work. So you can use the kerrison, but for kerrison to become useful, many times you need to thin out the bone. And there, these drills are very, very absolutely important thing. So these are again the drill and burr. You can see they have some of drill, they are high speed drill or burr. They can be diamond or carbide, straight or articulating. You can change the direction of burr also while using it. And then there are guarded burrs. They are very good, like this one you can see. So the back side of this drill is guarded by this guard, and this side is only cutting. So the neural structure is cleared and saved from any kind of harm when you are using the guarded drill. So I would suggest that you should have a very good drill system if you want to do a percutaneous spine stenotic lumbar decompression and the interlaminar rule. And the best part, what is the difference between the these blunt sequential reamers that you cannot use them under vision. You have to use them under the C-arm only. But here you can use them through the endoscope in the working channel and under your vision, direct vision. You can remove the bone. So for the interlaminar purpose, they are the must, these drills. For the transfemoral also, you can use them if you want to remove the bone under vision. Then the Kerrison punch, which I have already told, different sizes, different shapes. The bigger, the more removal of bone. And they are also curved. Sometimes when you want to do the uniportal bilateral decompression and you want to remove the opposite side tissue, this curved Kerrison punch is very much useful. So all these things will come into the foray of your practice as you keep on practicing. So then comes the, without saying, medical good endoscopy tower. This is our tower at my place with a medical grade monitor. This is the drill. This is the radio frequency machine here. So you need to have a very good quality camera, light source, as well as monitor to do the work. Then some people suggest, not many people across the world are using this fluid pump. Must have seen in orthopedicians using it for the arthroscopies. Here we commonly use the gravity only with using the 3-liter saline bottles. But yes, if you want to use them, they are also available. They keep the pressure on the constant rate, and sometimes when there is some bleeding occurs, you can increase the pressure accordingly. So you may or may not take it. And then complete OT setup. So those, my friends who are coming from the anesthesia background, sometimes they confuse the pain medicine and the MIPSs with the normal nerve blocks. So this is not so. Spine endoscopy and all the MIPSs which we do in the pain medicine are complete interventions, complete procedures, and they require complete asepsis. And for that, they require a complete dedicated pain medicine OT. Like this is, you can see in our pain medicine OT at my place where I am working. So here you need to have anesthesia workstation, C-arm fluoroscope must, endo tower, and emergency equipment and traps. That goes without saying. So they are not some blocks which you can give in the alley of your OT or in your office. They are complete interventions, MIPSs, and you need to take the utmost care for the benefit of your patient. And then most important equipment, that is a very competent team. Here you can see that Dr. Shivani Rastogi, she is my colleague and fellow pain physician. She is our OT sister. She assists us with all the equipments because these all equipments are very costly. They are very fragile also, and they need a very good quality care. And this man is who runs our CR. You need to have a very good, dedicated, understandable, which you actually have taught person who can run and understand your needs running the equipment. So otherwise that you may be lost into a maze where there cannot be a way to come out. So thank you very much. This is so thank you from my institute. This is Dr. Ramano Lohia Institute of Medical Sciences, Lucknow. So Pankaj bhai, I am open for any question, and I am again very much sorry for the technical glitches we had almost throughout.
So guys, if you have any query, if any questions, you can ask him.
Hello.
I'm sure there are many questions in your mind, but at times we just think that why should I ask such a silly question? But nothing is silly. Remember, this is just a training program, so you must clear your doubts. This is the right time. Clear your doubts. We still have some questions after doing endoscopy since last maybe 8-10 years now. We still get some queries in between. So I'm sure that you also must be having something.
Sir, good afternoon, sir.
Yeah. Good afternoon.
Sir, what irrigation fluid should we use, sir,
Just a
while
moment.
doing
Just a
endoscopy?
moment. Please come again.
Sir, what
Good.
irrigation fluid should we use
Normal
while doing
saline.
it?
Normal saline.
Do we need to add any antibiotics sort of things, or can we go with
That is
plain?
personal preference. My preference, I add ceftriaxone 1 gram in one bottle. And also I use sometimes one ampule, that is 1.6 milligram of 1 milligram of adrenaline into a 3-liter bottle. So just hoping that it may decrease the chances of bleeding. But that is not necessary because you are giving IV antibiotics in any case, single shot IV antibiotic.
Thank you, sir.
So most of the institutes, they have their different own difference, preferences.
Yeah.
So maybe in your institute, if you have some preferences, then you can choose that also. But usually we give around 1 hour before the endoscopic or any interdiscal procedure before entering into the disc. So at least 1 hour before the procedure, we usually give. I think that is the protocol everywhere, all over the
Yes,
world.
that is the right
At
thing.
least 1 hour, 60 minutes. So that is must. Rest all is like your choice or your institute choice.
True.
And remember, as we discussed, I think we are not discussed yet about this, but when we use the irrigation fluid, be very careful about the pressure. Don't, because we are working in the epidural space, especially when you are doing outside in technique, we are totally in the canal, in the epidural space. If you use too much of high pressure fluid, there are good chances that there may be some exhaustion and that may rise a ICP also.
Yes.
So there are case reports. There are case reports of some blindness and some ICP increase. So if the patient complains of some neck stiffness during the procedure, the most common reason is because of the prone position. If the patient is lying prone and head on one side, so that is definitely one most common cause of neck stiffness. But don't just ignore it. If the patient is repeatedly complaining of some neck stiffness, that is one of the sign of increased ICP.
Yeah. To avoid
Correct,
that
Anurag?
thing, that fluid overload only,
Yeah.
they have made 2 irrigation channels. If you remember, in the spine endoscopy, yes, there are 2 irrigation channels. So one is inlet, one is outlet. So you should not block the irrigation. For some time it is required to stop the bleeding, to see the bleeder, but do not stop the irrigation channels for more than few seconds, because that may increase the pressure inside the canal, or that may also cause the neural injury in the rare cases.
Yeah,
So
true.
certainly pressure is important. Do not increase the pressure too much. This is the reason we use the gravity only, not the pump.
And especially when we go inside, if we are doing inside out, when we go inside the annulus, at that time, there's hardly any requirement of any fluid also. So
Yes.
just a flow of the fluid is sufficient.
Yes.
So you don't require any pressure there.
Yes.
So this is how, if you ask some question, there are multiple things will come out. So you need to ask questions. If you'll ask one question, we'll tell you 10 things.
So question, sir. Hello, sir.
Hello.
Yes.
About the fluid itself, can we use the water or aquabides for the irrigation pump, or it is only allowed for using the natrium chloride or sodium chloride only?
I think water is not a right thing, because that is hypotonic. So there will be more absorption of fluid,
Absorption, yes.
which may put your patient into the fluid overload. So this is the reason normal saline is usually preferred. What do you say, Pankaj bhai?
Yeah, absolutely correct.
Yeah. So water is not because
Water is not.
there can be issues for the sterility also. I don't know whether we get Style,
I
you are
think
calling a
in
style water.
in India, I don't think we get a water, sterile water. We just get sterile water only for the dilution purpose. But we don't
Yes.
get like in liters. We don't get that in
Yeah,
liters.
1, 2, 3 liters we don't get.
Uh,
Okay, thank
Bipolar
you.
also will not work with water. You need the electrolytes for the bipolar to work.
True.
So, you issue why water can't be used.
Yes. True. That is also true. Because that might not work. The radio frequency might not work there.
Good evening, sir.
Good evening.
Sir, for prevention of the infection during endoscopy or after endoscopy, which antibiotic we should use and to how long?
Actually, for the any intradiscal purposes, the traditional understanding, and there have been few papers which were published way back in 90s, that 3 antibiotics they have found the one useful, and they actually measured the intradiscal milieu after giving the IV antibiotic. So the one was the cefazolin, third generation cephalosporin, but that is not usually available in India because it is very cheap. And second was cephalosporin, if the cefazolin is not available or something like that. And third one, I remember correctly, is vancomycin, I think. So the most commonly used antibiotic here in India, we use ceftriaxone. And usually, the most of the people think that one single shot antibiotic is good enough because you are actually not invading too much of tissue. And you are also putting only one stitch afterward in most of the cases. But in my practice, we give one antibiotic shot in the evening also, IV antibiotic. And after that, we put the patient, we give some broad spectrum antibiotic, oral antibiotic for another 5 to 7 days till the stitch is there. So this is our practice, but that again depends on the institutional practice and where you are practicing. What is your antibiotic policy in your institute? Something like that. And for as far as the asepsis is concerned, I have already stressed upon that. So they are not simple nerve block or something like that. They are actually on the side of surgery. So you have to take that kind of precautions every time when you touch your patient. You clean your equipment. Uh, so this is how it goes.
Excuse me, sir. One more question.
Please.
Is there any difference if we are using the local instruments or any standard company like Spine or other?
Lot of difference. Now, Dr. Manohar, you are from?
Sir, I am from Rewari nearby Gurugram.
Yeah, so those there are a lot of
Actually, sir,
differences
actually
because
I'm using some local instruments and Spine also. And
Mhm.
when we were using the local instrument, the rate of infection was more.
Okay. When you use local
And
equipment,
some
infection goes up.
corrosive material also there when we autoclave the instruments, which is
Yeah.
not found with the Spine instruments.
That you have answered your question yourself. So
Yes, yes,
good things are good always. No, they are costly because they are good. So
yes, sir.
I would suggest that you invest in a good equipment. Always invest in a good equipment and use them because one complication gives you a big setback for you as well as for your patient, and you lose your confidence, lot of confidence. This is not advisable to use less quality equipment.
And sir, it is advisable or it is beneficial to intraoperatively irrigating fluid contain any antibiotic like gentamicin or other.
No, my practice is that I mix. I like to take extra mile for again thinking that though I am taking all kind of possible aseptic measures, but still I load my 3 bottle with 3 liter bottle with 1 gram of ceftriaxone. So this is my practice
Ceftriaxone.
again, but I
Okay.
said this is not mandatory that you do it because in any case, IV antibiotics are must single shot, half an or 1 hour before the endoscopy, and after that you lace your fluid. Some people across the world do lace their fluid with the antibiotics, some don't. So again, there cannot be a blanket statement for that.
Thank you
Dr.
so much.
Datta, Dr. Datta,
Yes.
sir, what is your protocol for the antibiotics?
Datta sir, unmute yourself.
I usually use cephalexin, which is the generation before, which is available here, and I use gentamicin. So I usually use both coverages. If they have an allergy to penicillin, which some people do, then we use either vancomycin or Cipro. Cipro also has got very good coverage. If you're asking for antibiotics, Cipro has got excellent coverage. I don't know what the version of Cipro that you guys use in India. One version of the whatever ofloxacin drug is available, that gives pretty good coverage. Now, in the US, if you get an infection, it's a big problem. So that's why I give coverage for like 5 days with antibiotics. And I agree with what Dr. Agarwal was saying, that because you have so much of irrigation fluid and it's minimally invasive, the chance of getting an infection is less. But it's just to kind of save myself from getting an infection that I give it for 5 days.
Same as my practice, sir.
Yeah.
So I think Pankaj bhai, it's all for today.
Sir, excuse me, sir. Can you
Yeah.
explain that cautery thing, sir? I didn't get that. The cautery once, I think. There is no lateral flow of current.
Yes. The
So
higher,
I can explain that,
uh,
Anurag, I can explain that. So
please
basically,
go ahead, sir.
basically for the bipolar to work, you need an electrolyte field. If you have just water, you don't have the electrolytes that can make the
No,
current
sir.
work.
He's not asking that. He's asking about the hertz. I showed them
Oh,
the
okay, okay.
4.1
4.2
megahertz.
hertz. Yeah.
Okay.
Hmm.
Okay.
Yeah. So about the lateral spread of heat. Hello.
Yes, sir. That
Yeah.
cautery thing.
Actually, Jay, the thing is that all the cauteries, the normal surgical bipolar cautery, that can also be used, but they have got less power. Like they are usually of half to 1 megahertz. So that there the lateral spread, like suppose this is the probe, and here is the marker which is causing heat. So the heat should spread only ahead of it. So this is the reason you touch the tip of your cautery with the tissue which ablates it. But when the power is less, that if it is a 2 megahertz cautery, the lateral spread on these the sides of spread heat is more. So as you increase the hertz, the lateral spread of heat becomes less. So the 4.1 megahertz, they have measured it, the lateral spread of heat is only up to 0.6 millimeter. So that means if you are 1 millimeter away from the nerve, still you can use your cautery. And suppose this lateral spread is 2 millimeter. So you need to have minimum 2 millimeter or more than that space between the neural tissue and your cautery. So that it may more the megahertz of the machine, more safe it becomes to work near the neural tissue. That is the thing which I was telling.
So, guys, any other question?
So how you sterilize the endoscope, sir, by autoclave steam or by ETO, yeah, so
We do it in the STRAD plasma sterilizer we have.
plasma.
Though they
Oh, yes.
are autoclavable, as the company says, but we don't autoclave them because of the fear of getting it mm, getting it defected earlier than the life, because it's a costly equipment, you understand. So but for
Yes.
the rest of at my place we have got plasma sterilizer, so we do it that. But otherwise hand equipments can be very well autoclavable. They all are steel made. So but here the lens is very precise actually in the rod lens. that endoscope. So we do the plasma sterilization.
Okay, sir. Thank you.
But ET is also good. Like
Yeah,
you can do
ETO you can also do.
If you have the ETO in your, like most of the places, they don't have plasma sterilization. So ETO, I think, is everywhere. So ETO is
Yeah.
also good enough.
ETO is also reasonably good.
Yeah.
Sir, excuse me, sir.
Yeah.
The other instruments of the endoscopy, can we ETO or only autoclave?
No, they can be ETO. ETO is considered to be better than, but at many places, even ETO is not available. Or ETO somehow for few hospitals, they say that it is more like running cost is more for ETO and more for plasma than the simple autoclave. So you can certainly autoclave them. Like they are made up of steel. So no issues with them.
And the issue with the ETO is that you have to have like 10 hours of ETOs running is required. So again, that is one issue. Whereas you can be ready with for your next case after 2 hours only.
Yeah.
But if you have to go for the ETO, you'll have to wait overnight.
Yes.
So our endoscope can be placed in formalin chamber also, because
Yes, you
sometimes
can.
the company people are denying, not allowing that don't ETO or don't put in side X also.
Actually, bichare, they cannot allow you for many things which we usually do in our practice because they are bound by their company guidelines. But yes, it's a very common practice to put it in the fumigation chamber as well as into the side X. Sometimes we also do it if we are having two cases and we don't have that much of time for the plasma sterilization. Sometimes we do it. And this is a common practice with all the laparoscopes and all the endoscopes. So.
Yes.
But if you're using formalin chamber, then just be very sure. Firstly, I won't recommend that formalin chambers. But if you're still using a formalin chambers, be sure that you wash them properly before using it.
Yes.
Yes, sir. Thank you, sir.
So, question about the technique, sir. Is it allowed about outside in technique?
Yeah. That.
I think that we
Yeah.
will be covering during the procedure. We'll cover
Yeah,
everything.
gradually in the
Inside,
due process.
Yeah.
So that will be more understandable then.
Because right now, though, he won't have any pictures also to explain you.
Okay.
So there we'll cover everything. Like we covered like the complete anatomy and MRIs, everything. So we'll go gradually. We'll do that. We'll cover it.
Okay, sir.
Okay then.
Thank you so much, sir.
Yeah.
Thank you so much, sir. Good night.
Thank you.
Thank you, Vinay. Thank you so much. Thank you, sir.
Thank you
Bye,
very
Datta.
much.
Thank you.